2 years ago in Melbourne, Australia, we had our first Malaria Congress, which was called Finish the Fight. And we had about 110 people there. And we talked about malaria the day before the RI convention started. This time, we had the Global Malaria Eradication Convention Conference yesterday, and we had 155 people. And we brought in some experts from around the world, and we felt like, hey, they sure traveled far. We'd like to share some of their ideas and thoughts in an informal gathering. And I'm glad that you're here with us. We don't have a strict agenda, but we are also going to invite folks who are here who spoke yesterday, and we're going to have some interaction with the audience. And hopefully you learn about malaria, you learn about how Rotary interacts with malaria, and we'll kind of wing it. We have never done this before. We didn't know if we would have 5 people in the room and 200 online. We might have had 20 online or 2 online and 4 people in the room, but we do have a good turnout here in this room, so we're pleased about that. Drake, do you want to say anything before you introduce Marcy?
Sure. Well, why don't I take us back to the beginning before we get to Marcy? In the beginning, so one of the core group meetings, I had all those Zarathustra there. If you remember the start of 2001, A Space Odyssey, had this big horn music and timpanis and that. So in the beginning, there was malaria. And then there were Rotarians in Australia, and then Rotarians in the US. We got together in Taipei Convention in 1994 and formed RAM, which turned into RAM Global and RAM Australia. Gary, would you stand up? You're our Australian representative here. And we may have some Australians here, but it is middle of the night there. Brochures, yes. And so RAM Australia focuses on 5 countries. They're really doing fantastic work. They are the first Rotary group that has gotten a country completely to 0 in Timor-Leste. Hooray! And so as good Rotarians, we're stealing all of their good ideas. And that's one of the things we do. We steal very effectively and then share those ideas. Well, fast forward a couple of years and another timpani symphony entrance. And the guys had done the research that wide area use of nets would lower malaria dramatically and lower deaths. So they one of the guys, researchers, showed up at the Calgary Convention in 1996. We ran the story around, what does malaria need? We used the Disney creativity strategy and came up with 2 basic findings. 1, get nets to everybody. How are we going to do that? We're going to put treated nets, insecticide treated nets, to every vulnerable person, children under 5 and pregnant women in sub-Saharan Africa. Well, it took us about 6 years to get that done, but that's where Marcy comes in. And the second thing is, we said malaria central. We need a database of all that's going on in malaria. So essentially that's what you need to know about malaria. But at that convention, we said, let's put nets in vaccine campaigns. Well, 6 years later, the Measles Initiative said, yeah, we'll do that. And 2 years later, well, that was the first pilot project. You've heard of going to scale? Proof of concept, first one. Going to scale is second. We did 4 districts in Zambia in 2003. 2004, we went to Togo, full country, and the wonderful, freshly minted doctor, Marcy Erskine from Canada, came and joined us there, and this was wonderful. So any good effort, overnight success, takes 20 years of background work, wouldn't you say? And that 14,600 nets were a Rotary matching grant. 200 million or so nets got distributed this last year, coordinated by the group that Marcy runs. She's the logistics chair. And now we're on to introducing the global work that we're doing. We have as other speakers. Yes,
before
Dan?
we do that, I think we want to finish what we started earlier this morning, our award for Marcy.
Marcy who's is known as Wonder Woman in Alliance for Malaria Prevention. We give away capes. They're global awards. The Rotarians won it twice, and then we give away capes, and these are quite happy and famous. And their whole countries. I think the Mozambican group said we're doing all of our work so that we can each get a cape the following year. So in Uganda, if you go to the National Malaria Control Center, guess what they have on the wall? A net. The Australians have one. So this can cause you to fly and do all sorts of stuff. So part of my job is do a swirl. There you go. Yay, Marcy. So she takes teasing really well. She talks really fast and does extraordinary work. Yes, so we can't wait for your presentation. The other speakers are Jimmy Opigo, who's a National Malaria Control Manager for Uganda, and we have Richard Maud, who's a UK professor who's based in Thailand, who teaches there, and he has as many letters behind his name as some people who happen to be speaking right now. So I'm really happy for him to be here because he consults with all of the malaria control programs across Asia Pacific and knows a lot about this. And so I see Dan behind me. So now I have one Marcy story to kick this off. Okay. Marcy, so when you're distributing nets, often they're working in war-torn countries. For polio, we know of days of tranquility and days of peace. So in Central African Republic, which is partially controlled by one group and by another, a group of rebels stole a truck of nuts. And so what did Marcy do? She says, get me their number. Give me their number. Come on, give me their number. She gets them on the phone. Hi, you are so-and-so. This is all in French, so I'm just going to do the English version. You have our nets. We want them back. Yes, we're going to give you, there's some of yours in there, but we want the rest of them back. Do you ever talk to anybody with an AK-47 in their hands like this? This is Marcy. So Marcy, she's also Canadian. So a lot of what has happened in malaria control and continues to happen is run by Canadians.
And she flew in from Geneva, where she lives. So she came a long way to tell us a few things. And we're going to give her about 10 slides worth right now so we can get this rolling.
Yeah. One of our favorite people in the world.
So all that embarrassment actually, it got my flight home for the summer. So I'm going to accept that that's where we are today. I'm going to put a bit of a different hat on. I work at the International Federation of the Red Cross. So I also am the lead for the Alliance for Malaria Prevention. But today we're going to try and link those two things a little bit. Yesterday I presented on some funding stuff. And so let's start with some interaction with the audience. How much of the money into malaria do you think is covered by the US government through their contributions currently to date? So let's try 25%, 50%, 75%. So currently you're still at the same place. We don't have a change. Yeah, we don't have an official change, supposedly, yes. Yeah. 25. It's about 50. So globally, between the US President's Malaria Initiative, which has recently obviously closed, and then their contribution to the Global Fund, the largest funder for HIV, tuberculosis, and malaria, the US government has been funding about 50% of malaria control. So as we start the presentation, it's important to think about what are we doing moving forward, because the context is obviously going to change significantly. And as we know, the last cases of polio we've found in communities, the same applies to malaria. So let's try and link a little bit your priority with community health workers and our priority on not losing focus on the goal of malaria. We're not going to have enough money, but we don't lose our vision. So next slide, please. So here, I don't want to spend too much time on this with you, not get too technical. What I wanted to do is just highlight this part at the bottom right from the 2024 World Malaria Report. So really emphasizing out of the data that they were seeing, the need for a more inclusive and effective response with a focus on reaching the populations most vulnerable to malaria. And as we know, a lot of those populations will live further than 5 kilometers from a health facility, not have easy access to care. So these are the people that really our community health workers are linking to health services through their work. So next slide, please. I wanted to just highlight this. This is from the Red Cross, and every organization has something different. So I'm just using this as the one that we use. So we have sort of different levels of community health workers or community volunteers, and that means that they can do different things because, you know, you can't be a lay volunteer with no training and go and give an injection. That's not really going to probably work in any context. So this is really around saying, you know, there's a really informal role where, you know, you've got volunteers doing mobilization and other activities, not really providing health services directly, then kind of a higher trained role that would do more things like integrated community case management. And then, you know, a higher level again, that might be that link between a facility and a community health worker. So providing that supervision and oversight. So next slide. So this is a map of the Democratic Republic of Congo. So we just talked a little bit about, you know, what's going to happen as we don't have enough money. And in this example, and again, as I said yesterday, it's complicated graphs. I'm just going to give you the key message. So as we don't have enough resources, we need to prevent death, right? We want to prevent death. So always we have to have case management as our first priority, so that when people get sick, they can get a diagnostic test and then they can get a treatment. So what that means is if you have $100 million and you require $60 million for case management, that leaves you $40 million to do the rest of what you need to do in your country, including prevention. And so in this case, in the DRC, you can see there's a massive change. So what happened in the left side of the image, it's basically just these prioritization by case burden, different indicators. And on the right is a map of how much malaria would increase if we withdrew vector control, so mosquito nets, completely from the DRC. And so those really dark colored areas, you can see those are increasing by almost double. So when you look at that, then you have to think, okay, but if I withdraw all of that prevention, my case management costs go up significantly. So somewhere there's got to be a sweet spot between prevention and what we can afford in case management and what we can afford. And that's going to be a very complicated exercise over the next couple of months, which Dr. Opigo can speak to better than I can. So next slide. So again, as we change these intervention mixes, so, you know, where you have nets, where you have seasonal malaria chemoprevention, where you have a vaccine, as we do that, it's going to mean that we're going to see some shifts in what's happening to malaria as a disease. So CHWs have really important roles to play as we go through this transition. So timely care seeking behavior. We're going to have a lot of people who think their malaria risk perception might be low. They've always had prevention. They've had a very low number of malaria cases. All of a sudden they don't have prevention and they don't perceive that those are malaria cases. And we need those people to get to a health facility, get diagnosed and get treated. So where we're removing vector control, large scale vector control, we do need to think about how CHWs are going to make sure that people who get sick do not die. They get a test and a treatment in a timely manner. Timely referrals. So same idea. And this can be either to communicate about them to make sure that people know to go, or it can be to facilitate them. So put them on a bicycle, get them to a health facility for people who are very sick, make sure they get care. And again, to data, Drake's favorite point, data, data, data. You know, we're not going to be able to do these big surveys anymore that we used to do. And we need some way to take programmatic decisions and actions. So CHW data from the community level can be very, very powerful for us to be able to do that. So next slide. Okay, and then, you know, when we're able to adapt to the context, we improve our outcomes and our impact. And I think that's very clear. That's what community health workers bring. They bring knowledge, they bring all of the things, they bring living in the communities that they serve. And I think that allows us to, without even speaking about it, at least address some of the issues we see around equity, human rights, and gender, in particular in some of the hardest places to work in the world. And then we also achieve the maximum benefit. So when we work with communities and with people in communities, we often improve our uptake, our adherence, and our use of what we're trying to do. Next slide. So information is power, trust is needed, and listening is critical. And I think these are really important things for, as we think about community health workers. And that flows both ways. It flows between the community health worker and the communities that they serve, but it also flows between the mechanisms and structures that oversee the community health workers. So it's a system that needs to work together for the community health worker to always also feel motivated to continue the work they're doing. So community health workers provide information, they advocate for decisions taken. We don't all like them, but we have to make sure that people understand them. They manage disinformation and rumors, ensure the community feedback systems are in place. And as we change what our landscape looks like, we're going to need community feedback. We're going to need to listen to people, and we're going to need to see what's happening. And finally, they build trust. And that is something that you should never take lightly on what community health workers can bring. Next slide. So yeah, just an important role in ensuring everyone's reached. This is from a program in Cameroon. I won't go through it, but really, mapping, GIS mapping of where people are, what's happening, and really pointing out something that came out yesterday, this multi-sectoral aspect of things. So we're not going to solve all of these problems on our own in a malaria community. So in here, you're looking at health and WASH and food security and education. Many of our programs with our community volunteers and the Red Cross also include animal health, just recognizing the difference, what's happening with our animals, humans, and environment, and that interaction and how that affects health. So things like rabies and interactions between bats, how that, Ebola. So understanding those interactions a little bit better, it can only improve our outputs as well. So next slide. So community-based surveillance, I think, will be important. And I think here, Richard can speak a lot more to this than I can. But some of the advantages of this, it's community-driven, typically integrated. You can do other disease monitoring at the same time. Event monitoring. So, Mpox events, we've seen obviously COVID, we've seen anthrax, we've seen rabies, so different things that come up. Crisis response for when you have emergencies. And then ideally, it's a cost-effective solution, right? So it's low cost, sustainable, and ideal for resource-limited settings. So something, again, for Rotarians with your interest in CHWs to continue to focus on, for us with a malaria lens, but obviously with a broader lens as well. Next slide. I think this should be the last. This is just talking about an ITN campaign, a very insecure part of Cameroon, so in the Anglophone part of Cameroon. And I just took out the key messages here. So what made this work? Presence of trusted NGOs, active CHW network, the community's ability to organize themselves, which comes with building these community health networks, and commitment of campaign actors living in their own communities to make this happen. Next slide. So I think this is the last slide. Community health workers are critical, and I think we have to recognize they're potentially at risk. CHWs and community health systems can be focused on tailored packages of interventions to respond to community priority needs. So it will never be a one size fits all, right? What works in one community won't work in another. So it's a very localized response, and it's very tailored, and that's why it's so effective. But we need to build these networks to sustain. And that means we need to ensure government buy-in, and we need to plan for a transfer of ownership and responsibility. And we need to make sure we're not duplicating around each other. There's enough of a gap in this space that I think we can all find somewhere to work. So all to say, we need to do more with less and do better as a community to get to where we want to get to. We need to advocate for sustained funding and use the data to tell the stories of the outcome and impact. I think we're not probably doing a great job of that. I think we tell nice stories, but I don't think we put a lot of numbers behind them, and numbers tell a story in a different way. And I think that's very, very important. And finally, motivation takes a lot of forms, but, we see the economic crisis hitting everyone globally. And as you can probably imagine, in the poorest countries in the world, it's increasingly horrible for them as well. So whether you want to motivate in different ways, still there's some financial motivation is probably important for these people. As we give them more and more and more to do, you can't ask them to do more for nothing and still expect a quality delivery. So figuring out ways to keep people motivated will be something really important so that we don't risk the collapse of these systems with external funding as it goes. And that's it. Thanks.
How should we do this? Have Jimmy and Richard come?
My thought was I'd like to open it up to a couple of questions, and then we'll have Jimmy come up and talk for a bit. He doesn't have slides. And then we'll have some questions, and then we'll have Richard come up and we'll have some questions and answers. So does anyone want to ask Marcy something at this point? This is supposed to be interactive, so somebody is in the back there. Go ahead. Okay, Marcy, come back up and explain the question in case somebody might have missed it. Thanks.
So the questions around payment of CHWs, I'm actually going to get Richard and maybe Jimmy to come in as well. Payment's important. You need to pay people for training, and you need to determine sort of how much training they need. I think the best way to pay in the best system I've ever seen, it was a small system where the community health workers worked together and they got a monthly stipend. It was quite small. I think it was like, let's just say it was $15 or $20 at the time for a month. And what they did is they took a third of that money, each of them. So if there were 10 of us, we each took a third every month and we put it into a pot. And each month that pot would go to one of the volunteers. And then they could use that to, for example, buy goats that they could then get milk from, that they could then sell the milk. So it was a whole different way of thinking about the motivation system. And I thought it worked really well because it also forced people to work together. I don't think we're currently at a place that we can get away with paying nothing for what we're asking for. And I think there are risks with that as well. But maybe Richard or Jimmy, do you guys want to come in on this one? Of course you do. Well, you're right here. You can come right here. You see it right there.
Okay, thank you. Good afternoon. I've had a fairly long experience with community health workers. In my earlier life, right after school, I went to work in primary healthcare setting in a health district, about 200,000 population. I didn't work necessarily on malaria. I worked on all primary healthcare actions. Maternal health, immunization, and HIV actually have utilized community health workers more comprehensively, following up mothers at home, identifying those who have risks, organizing referral. And initially, we had even what were called traditional birth attendants. Right now, they're being phased out because the system has grown. There are more professional midwives to attend to birth. But for a very long time, this was run by community health workers. And our work was to deal with the hygiene, give them some packs. We call them mama packs, so that there's cord hygiene, padding. Would make this available, and they will do all this type of work. For immunization, they worked a lot for what here is domiciliary service. But here you have telephones, you can call and remind mothers to bring their children for vaccination. In the villages, there are no roads, but they know all where the children are. They go and get them up. If it is a drop vaccination, they can drop it. If it is an injectable one, they move or gather all the children in one location under a tree, and a health worker comes and delivers the vaccination. For HIV, they do various work like adherence counseling, checking at homes, how nutrition is, if people are adhering to treatment, because this is chronic treatment, peer support. And in the recent past, Malaria has done a good job utilizing this. And what the health system in my country did is to put what were initially specialists in different areas. For like neglected tropical diseases, they were called CMDs, community drug distributors, because we would give those anti-helminths once or twice a year, and they will go home to treat people. So we have had to put them together, and you multi-skill them to do what Marcy has done, various things, information giving, danger sign identification, referral, and even now actual case management. Malaria uses them really a lot, especially for distributing mosquito nets home to home. Hang up campaigns. Some people are so careless that they need to be helped to hang up a mosquito net. They have endless excuses. So someone has to come and pin things on the wall and hang it, and so demonstration, from nutrition, everything to demonstrate how things should be done. When we do residual indoor spraying, they're the ones who go with the pumps, move everything housed, spray the homes, and then put them put them back. Where we are doing seasonal chemo prevention, they are the ones who go and give the medicine for all the children. Now, about payment, right now there is a strong advocacy about three things: that they should be digitized, compensated or remunerated, and skilled. So a very good package of training has been developed for the three categories which Marcy has talked about, depending on their background. The very basic, the lay ones, is really 2 days to 1 week. So there's a proper package of training so that they're properly skilled and regularly updated. Now, where possible, smartphones are made available, or there's a concept, bring your own, where they have, and an app is given, which helps them. You send education through the app. Even when they're running a service, there's an inbuilt business intelligence. We say, you now do this, you do this, you miss a step.